Good morning, and thank you for the invitation to speak, and thank you to our hosts for welcoming us here in Thailand, in Bangkok. I want to talk about the role of occupation, which I think has been relatively neglected in the past. This is my disclosure. Work is funded by the United States Department of Energy. Actually, we've had it for 25 years, but I haven't checked my email today, so I'm not sure of the funding status. So to state an obvious thing, actually success depends on actually people showing up and getting screened over a long period of time, 20 or 30 years of annual screening. And I've abridged some of the essential elements of screening to really focus on some work-related aspects. I won't really read these to you because I'm going to go through them one by one. Occupation has been relatively neglected in terms of determining eligibility. I'm going to show you some of the guidelines from various countries, and you will see what I'm referring to. It has also been neglected in identifying important populations that should undergo screening. And then finally, I've lately realized that I think occupation can be important in terms of uptake and adherence to screening, which has been a real challenge, at least in the United States to date. So here, I show just some of the guidelines or recommendations or what's been used in studies in various countries. Here in Thailand, in northern Thailand, age, smoking, but in addition, family history and COPD in Taiwan. And I know we have people here who have been investigators in that study, in the talent study, used a somewhat broader group of eligibility criteria, age and smoking, family history, but also chronic lung disease, TB, and the cooking index. So we have an environmental exposure. In Europe, various risk models have been used. I think you're probably familiar. Basically, age, smoking, also family history and personal history of cancer, chronic lung disease. And then there are a couple of models. I'm thinking about the Liverpool model in particular that at least asks about asbestos, but it's a yes or no response, so it's really treated very superficially. And in the U.S., we keep it very basic, just age and smoking, and leave the other factors out. Interestingly, I found in China that the official screening guidelines include the usual suspects, but also a long-term exposure to various occupational carcinogens. A number of them, actually, not all of them, but probably the most common ones that are seen. So occupation can be used to determine eligibility. And I want to just show a couple of slides on the role of work in producing lung cancer. It's said to be responsible, at least in higher income countries, for contributing to 10% of lung cancer. There's a lot of overlap with smoking because a lot of blue-collar workers also smoke. And so there's a contribution from both. If you look at individual lung carcinogens, actually the relative risks are significant, whether it's asbestos or silica or the like. And then well-known supra-additive interaction between smoking and occupational carcinogens to increase lung cancer risk. This is the list from I-ARC, from WHO, of recognized human lung carcinogens. I won't go through them, although I would point out that there's some pretty common exposures. We have silica is a relatively common, diesel exhaust, and some of the metals, and certainly outdoor air pollution is just demonstrated by the last speaker. Asbestos is unfortunately still with us. The United States banned asbestos in the past year. There have been some 60 or 70 countries that have banned asbestos, but there are some countries that still produce and use a lot of asbestos. And you can actually match up industry, exposure, and job title to begin to understand who should be screened. The way we think about it is that we could probably use usual job title in your lifetime as an abbreviation for identifying risk. Also, the duration of employment in that title, but the usual job title is synonymous with long duration jobs. And then secondly, go to industry and specific carcinogens. And we've written more about this in an international consensus statement out of the Collegium Ramazzini, published about a year ago, if you're interested. I also think that identifying work is useful in looking at populations who should be exposed. And we know in the US that uptake in general of lung cancer screening, even though approved now 10 years ago, uptake has been very slow. And the question I raise is whether certain populations can be identified that would have an increased interest and increased uptake and increased adherence. And I'm going to show you our data in a minute that I think demonstrates some of that. If you're interested in the work-related aspects of screening, then you can identify either through the workplace employers or labor unions. You can identify through the government various ways of looking at high-risk subpopulations that have occupational exposures. So finally, I want to just talk about how identifying workers at risk can actually lead to better participation in a screening program. And here I want to talk about our work. Over the last 25 years, we've been screening nuclear weapons workers in the US. So these are people who were involved with building our nuclear bombs in the US. First started in 1943, but we're really talking about the workers we've looked at in the last 25 years, really started work in the 1960s, 70s, and 80s in the field. It's jointly done with the United Steelworkers, which is the largest industrial union in the United States. And here's where we're doing screening. We're located in New York, but we're screening all over the country. Some locations you've probably heard about, such as Los Alamos in New Mexico, Oak Ridge National Laboratory, and the Y-12 facility in Oak Ridge, Tennessee, and then throughout various places, Idaho, California, Nevada test site, et cetera. And the people we're screening are mostly rural. They're blue-collar workers. They're mostly white because that's the population that was employed. And they're older than the average person who participates in a screening program. Most are over the age of 65. And this is community-based screening. This is not medical school, tertiary care, tertiary medical center-based screening. This is community-based screening in various parts of the country. So I'm switching now here just to remind you about the factors that are associated with lower adherence to lung cancer screening in general populations, which is at lower socioeconomic status, lower educational levels, and people over the age of 65 are less likely to agree to lung cancer screening and then to adhere to lung cancer screening. And this is exactly the group I think that we're actually screening. We screen age 50 to 80. We use 10-pack years as a cutoff. We used to use 20-pack years when the US official guidelines said 30. We lowered it to 20. When they lowered it to 20, we've since lowered it to 10 because we figure that the occupational risk contributes to the overall aggregate risk that would constitute why they should have lung cancer screening. And we've screened over 14,000 workers, identified a lot of lung cancers, 230, but most importantly, it's a 3/4 early stage disease, which is exactly what the National Lung Screening Trial found. This is a community-based study, not our program, not really a research study. But this is one of my last slide, or next to last slide, actually. So I want to just show you our adherence to the annual CT scanning, because we've been offering annual scan for the past 10 years. In general, the studies in the US show adherence, initial adherence, say to the first annual or the second annual, at about a 50% rate, meaning only 50% people even come back for the first annual scan. We achieve close to 90% adherence, one scan to the next, to the next, to the next. And we do that, I think, for a number of reasons. One is this is our CT scanner in Oak Ridge, Tennessee. And you'll notice it's not at a hospital. It's actually at the labor union hall. It's in their parking lot. And we do this for a couple of reasons. But one of the reasons we do this is we want the population to understand that this is their program. This is a partnership with the unions at that facility, and that this is their program. This is not brought to you by a tertiary care medical center that you may or may not be able to relate to. And we think this partnership approach to providing this health screening process is one of the keys to successful adherence to scanning. The other aspect is external versus internal risks. You know, people in general tend to rate risks that are imposed on them from the outside much higher than the risks that they somehow participate in, say, behavioral risks of cigarette smoking. And if you look at the work-related exposures that put people at risk for lung cancer, those are external risks, as opposed to cigarette smoking, which, let's face it, smokers have at best an ambivalent feeling about health and about health actions they will take to protect their health. But for people who in the workplace who have been exposed unknowingly, usually, and certainly unwillingly to asbestos or silica or air pollution and the like, that's an external risk. And therefore, the emotional aspects of smoking, participating in a health action that's going to protect them is removed, and we really get to focus on external risks, which I think it helps in terms of adherence and may be relevant to other risk factors. And that's about it. Thank you very much.